of time. I'm glad that no introduction and thank you, chairpersons. I will genuinely not take much of your time. It's a Sunday evening. We've already kept a lot of people away from their families and home this weekend. But I appreciate the enthusiasm of the crowd for a Sunday evening. They're still here. And as always, thanks to Manoj Purvi, Vansi Bhai for this opportunity. And as the chairman has rightly said, I think this is the encompassing diabetes conference. If you see the topics from day one to now, it has really covered the entire spectrum of diabetes patient care. And I'm sure this topic also will add to that. So I am here to speak to everybody on herpes zoster and how do we prevent it in a diabetic individual. To begin with, we are aware of this slide, nothing new here, that diabetes overall has been a global challenge, is a global challenge, will be a global challenge till we do something about it. And to add to that, CKD is also rising. So combine these two together, we see that there is a huge cause of mortality with a diabetic landing up with a actually diabetic nephropathy and hence a CKD. Diabetes carries a high healthcare burden in almost 1 in 10 individuals predicted to have this combination by the year 2045, and that attributes to a lot of other comorbid conditions including a retinopathy issue. Diabetes also is a major risk factor for chronic kidney disease, which affects up to 1 to 8 in the global population. And look at the economics behind it, it's adding to a lot of financial burden as well to the patient and overall the healthcare system. We are talking about this in a topic of vaccination against herpes zoster, because if you see the small little bracket there on the left top, infectious disease are much more predominant in an individual who's diabetic and lands up with CKD. That is the reason these initial couple of slides were taken to show you that the moment there is a diabetic, there is a higher incidence of herpes for sure. The moment there is diabetes and one more comorbid, especially the kidney getting involved, there is even more chance of the individual landing up with a infection like herpes. And then what do we do about it? So thereby coming to my topic at hand, herpes zoster in a patient of diabetes mellitus. The association between them was established. We as clinicians have seen it in our daily practice. The research has shown it. Evidence has shown it. There is nothing new here. It's all being shown. All these reviewers over their past experience that have put on paper that diabetes is the independent risk factor for herpes and thereby post-herpetic neuralgia. The PNH stands for that. Patients with diabetes have a higher incidence of herpes zoster as compared to healthy individuals. And these are healthy individuals. So anybody who has diabetes automatically, if you see the graph, has a higher scale. And I would want to add on to this slide, it doesn't matter regarding the control of diabetes. We've all seen a well-controlled diabetic also has that bit of an extra chance of developing that particular herpes zoster infection. Probably the key lies in the molecular mechanics, the key lies in the immunogenicity, the key lies maybe in the lowered immunity over the period of time. But for sure, even a well-controlled diabetes has a little bit more chance than a normal individual. And what does that cause as an impact? It contributes to a glycemic deterioration. So not only does diabetes cause herpes zoster can also deteriorate a good glycemic control in your patient. It is noted that almost 24% of a well-controlled diabetic patient have increased A1C levels after a herpes zoster infection. And the risk of herpes is no different in all these comorbidities. We are discussing it with diabetes, but look at SLE, look at rheumatoid arthritis, COPD, cardiovascular conditions, inflammatory bowel disease, a kidney involvement, asthma, all of them have shown an increased incidence of herpes zoster. So multiple comorbidities, more the chance of herpes zoster is what this slide is saying. It's a no-brainer. It's an established fact. But the moment you have diabetes add on, so diabetes with a cardiovascular, diabetes with a heart failure, diabetes with a COPD, this goes exponentially higher, and that impacts the quality of life. So the moment we, as clinicians, I'm sure come Monday morning, we are all going to go back to our clinics and tell our patients walk more and be happy and healthy and smile more and be stress-free, and see what herpes is doing to all of them. They can't walk much, the relationship suffers, the normal workload suffers, the mood takes a hit, general activities, enjoyment of life, and the sleep, because of post-herpetic neuralgia is absolutely a deterrent. I mean, I'm sure so many of my colleagues here must have seen a patient of post-herpetic neuralgia complaining of pain and pain forever and forever if you don't treat that herpes or rather prevent that herpes in time. So all of these impact the quality of life. It negatively affects the health quality, as we've just seen, including the post-herpetic neuralgia. So not only the infection in the acute phase, once the infection has healed, the the enmeshment of the nerve, the dermatome involved, will lead to a post-herpetic neuralgia, which can also affect the quality of life. So that brings us to the next part, that we've seen what herpes does in a diabetic individual. So how do we prevent it? So we come to the efficacy of this particular vaccine. It's a non-live vaccine. It elicits a response against the varicella zoster virus. It enhances the immune system towards the viral antigen, and it also causes an adjuvant system. The AS01B enhances the immune response to IgGe, and thereby causing a robust immune response also at the time of vaccination, and a sustained one beyond it as well. So the long-term immune response also has been shown to be quite good in this patient of vaccination with herpes zoster. Shingrix was thoroughly investigated in two large pivotal phase 3 trials. One was called Zoe 550 and one was called Zoe 70. The Zoe 50 had, if you see the sample size, 16,000 plus individuals there, and the Zoe 70 also had 14,000 plus individuals there. One arm was given a vaccine, the other arm was given placebo, and what did they find out? They found out that individuals in more than 50 years of age had 97.2% of prevention of herpes happening when they were vaccinated, and individuals who are 70 years and above at 97.9. So a robust data came out of this trial of a large sample size of patients in both these age groups. It thereby significantly reduced the risk of both the post-herpetic neuralgia, the other complications related to shingles, and the efficacy was proven in both these kind of clinical scenarios. Thereby, Shingrix became effective against herpes zoster for people with medical conditions at enrollment themselves. So, people who have diabetes, hypertension, coronary heart, asthma, and believe me, gentlemen and ladies, when they come to you for a diabetes naive individual coming to you for the very first time, is the most amenable to all your suggestions. So when, for example, come Monday morning, you're in a clinic and somebody for the first time comes to you with a hyperglycemia report, is the most amenable of that time to, if you convince him for vaccination. That's what this slide is saying, that if you try to vaccinate a patient with comorbidities right on the first consultation, I think you've done your job well. The Zoe 11-year data, overall vaccine efficacy was shown to last quite a bit. 11 years is a long period of time of follow-up. Almost, if you see the confidence intervals, was very much statistically significant over the period of time. Adverse reactions, the left-hand side shows the local one. So pain, redness, swelling, nothing new there. Any vaccine you give, that's expected. Simple paracetamol can take care of it. And the right-hand side had little of fever, fatigue, systemic side effects of GI, headache, myalgia, shivering, if at all, but all transient, all short-lived, nothing permanent and nothing acute. The safety results support the favorable benefit and risk profile of Shingrix patient, thereby more than 50 years of age. It was overall compared with placebo, and a fatal side effects were not seen in the post-vaccinated individual as well. Thereby, it's indicated for prevention of herpes zoster, the Shingrix vaccine, and a post-herpetic neuralgia in any adult age more than 50 years, especially more so in a diabetic individual. It's given as 2 doses. Day 1 is the first dose, and between 2 to 6 months is the second dose of Shingrix vaccine. It's not to be freezed, it's to be kept in the refrigerator between 2 to 8 degrees Celsius. What about co-administrations? So all of these can be given with Shingrix. Influenza, pneumococcal, Tdap, along with Shingrix can be given. And as I mentioned, other than that bit of local effect and maybe a bit of systemic effect, there's nothing majorly seen in the patient. Therefore, it's by country approved in all these countries, and 92 million dosages have been given globally. To summarize the Shingrix bit, it has more than 90% efficacy across age groups more than the age of 50. It has a 11-year long-term protection seen, a recombinant adjuvant vaccine, a non-live vaccine. It's approved for ages and individuals more than 50 years, and it's usually well tolerated. So, coming to the last bit of my talk, then what are the recommendations of this vaccination in an individual with diabetes mellitus? So if you can give it to a diabetic, you reduce the chance of infection, even those will well manage the disease. So many times we are asked that, doc, I'm on diabetes tablet for the last 10, 12 years, my sugars are very well controlled. Do I really need a vaccination? The answer is yes. As I mentioned in the previous slide, a normoglycemic or a well-controlled diabetic also has a little of an extra chance of developing this infection. Thereby you vaccinate them. Individual with a high risk of serious complication from infectious disease compared to general population, thereby you vaccinate them. And therefore it's important to protect both these direct and indirect consequences of not vaccination. Most of the global bodies have supported Shingrix vaccination and diabetes. The CDC, sorry, the CITCO, the Italian Ministry of Health, and the ADA. Coming closer to home, our own API, the RSDI, the Indian Society of Nephrology have also given their guidelines and have supported vaccination of Shingrix to diabetic individuals. What's the schedule? As I mentioned, the first dose at whatever point in time, and the second dose between second to sixth month after the first dose has been taken. And that's the guidelines for people who are on immunosuppressives. What of people who are cancer survivors who are on immunosuppressives usually can be given. The two caveats are, if somebody is on rituximab and somebody is on corticosteroids, rituximab, wait till at least 6 months have passed till the last dose of rituximab, and then you give Shingrix vaccine. Corticosteroid, our patients offer multiple reasons on corticosteroids. You may, as clinicians, stretch your imagination, and right from reactive arthritis to so many indications we end up giving them. Wait till you have scaled that particular corticosteroid to less than 20 milligram a day, and then you give a Shingrix dose. These are the only two caveats to Shingrix. It can be surely given, but if you give it in these caveats, the patient is safe enough to take it. All the healthcare providers should be considering vaccination patients of herpes zoster, even those who have had herpes zoster in the past. Usually a time period of 6 months after the acute infection is safe enough to be given vaccination as well. That's the safety information. So to summarize, my last slide, ladies and gentlemen, there have been numerous studies who have been found to have more than 24% increased risk of herpes zoster in individuals with diabetes than compared to those without. A pooled post ad hoc analysis of ZOE 50 and ZOE 70 data has shown that efficacy of Shingrix against herpes zoster was 91.2% with diabetes, and the risk of serious adverse side effects was hardly there. The RSDI in India has shown that the Shingrix, the non-live vaccine, is the preferred shingles vaccine due to its higher efficacy, the longer duration of protection in Indian setting, that's 11 years, and Shingrix is a good option for any diabetic more than 50 years of age. Hospitalization rate, but not the length of hospital stay, was increased after the episode of herpes zoster vaccination. Thank you so much for a patient hearing. Thank you.